Thank you. So, in today's morning of Republic Day, we'll deal with further two abstracts related to HER2 positive breast cancer. So this one is for GAIN trial, which was actually discussed in previous slides as well. So, this trial actually saw 3-year invasive disease-free survival with chemotherapy de-escalation. We have seen so many trials for chemotherapy and targeted therapy escalation. So, first time we have some very good data for de-escalation. And this adopted both FDG PET and PAT-CR based response assessment to decide for the treatment. So the treatment design, it was not so simple. Treatment design, if you see, that included stage 1 to 3A patients. Tumor size should have been at least 1.5 centimeter or above. It should have been confirmed by either MRI or ultrasound, which is fine because ultrasound is very commonly utilized in our setting. Sonomammography is very commonly done. At least one of the lesions should be PET evaluable. So that was the main important point which should be taken. And I think when we do PET scan, we find PET uptake in the breast lesion very commonly. So patients were stratified for hormone receptor status. That was another good point which was at the back of the mind when we were reading the trial. Group A was TCHP 2 cycles. Group B, which was the interventional arm, which was dropping chemotherapy altogether, was using dual HER2 with or without endocrine therapy as per the ERPR status for 2 cycles. And after that, after 2 cycles, there was a PET scan which was done. If you see, PET responders were defined as there should have been resist response following cycle 2, and at the same time, SUV max must have reduced by 40% or more. So these were the two important points for considering PET response. This was very well specified in the trial. Group A patients continued to receive further 4 cycles of TCHP and then underwent surgery. Group B patients, if the patient had response defined by the proper criteria, they underwent continued further total 6 cycles of PH, that means trastuzumab plus pertuzumab along with endocrine therapy. If there is no response, they were shifted to TCHP. And if you see here, again, to make it very comfortable and comparable, they gave 6 cycles instead of 4 cycles here. So total 6 cycles of chemotherapy were administered. Moving further ahead, and these patients, if the patients achieved PAT-CR after surgery, even if they had response, they were given the usual maintenance treatment. If they did not have PAT-CR, post having PET response as well, they were shifted to the usual chemotherapy, TCHP 6 cycles, and then maintenance Trastu plus Per2. So the patient who did not have PAT-CR were given the entire treatment overall. And let's discuss the primary endpoint, that was PAT-CR and PET responders in Group B and also 3-year IDFS. So first point which was I wanted to highlight here is the node positive patients overall. Node positive patients were 45% and 49% in both the groups, which was comparable. Other point is that ER positive patients, it was in Group A, Group B, both were 60% and above. So it was well balanced study as expected. Around 80% patients in Group B were PET responders and received only PH treatment prior to surgery. And following surgery, PAT-CR rates were close to 40%, exceeding the null hypothesis, which is the first null hypothesis that 20% or less will be the PAT-CR rates, and it reached 38%. So what we understood, the patients who had PET responses and they were able to have PAT-CR close to 38%, they did not receive chemotherapy altogether in this trial. And if we see the IDFS endpoints as well, as it was 95.4% in this Group B, patients who had PAT-CR. So it was good that a primary endpoint was reached and patients didn't have distant recurrences more than the usual patterns which we see. Most of the time, it was ipsilateral loco-regional recurrence. Distance recurrences were 8 out of the total IDFS events, and it was 3%. Coming to the safety point, which is all we are expecting some improvement. If we see the grade 3, grade 4 adverse effects, it was 12.8%, that is close to 12% in Group B without chemotherapy, and as expected in Group A receiving 6 cycle TCHP, it was 65%. So that's the most important point which was being considered for treatment de-escalation. So these are the differences in the toxicities which we are quite understandable. So this trial concluded, this minded, this is the phase 2 trial. It concluded among HER2 positive, carefully selected early breast cancer patients, bed-based and then a proper surgical pathology based PAT-CR adaptive strategy led to an excellent 3-year IDFS 95%, and it could identify around 1/3 of the patients who could safely omit chemotherapy. So you must understand around 2/3 of the patient will end up receiving chemotherapy overall, but at least 1/3. It's not a very small number, but it's good. So we have some data for omitting chemotherapy altogether in carefully selected patients, and this included even node positive patients. So that is another very important point which should be taken home. Coming to the second abstract, which is about TILs, and I think we are moving towards an area, a world where prognostic markers will become more and more important in our treatment strategy, because there are so many treatment options coming up, so many escalation strategies are coming up. We need to understand where to de-escalate treatment. So this is a 10-year updated analysis of the short HER trial, which was a negative trial. So sometimes we dump the negative trials and don't discuss about that. But thankfully, this trial had something biomarker based that led to resurgence, and this was presented at ESMO 2024. So we know we need some of the biomarkers for early breast cancer so that we can identify where to de-escalate treatment. Short HER trial, or as we know, utilized just 9 weeks of HER2 directed treatment, and we are very excited about this trial because at one time, even trastuzumab giving in our country was very difficult, but thankfully in last 5 to 7 years, the situation has completely changed, and we are able to give 1-year trastu to 95 to 99% of our patients. So this trial had a de-escalation treatment strategy, we are all aware, and what we understand, tumor infiltrating lymphocyte, they took a cutoff of 20%, and this could clearly identify patients with difference in the outcomes on the basis of tumor infiltrating lymphocytes of 20% or less. With patients having tumor infiltrating lymphocytes still less than 20%, the outcomes were significantly different in the two arms. And if this study tried to identify whether there was a correlation between the two, between the treatment arms and as well as TILs. That is another important point which we wanted to see. I wanted to show you some of the graphs. Distant disease-free survival by TILs. So if patient is having receiving a shorter duration of the treatment, and TILs are, if you want to see the duration, this is the slide which I wanted to highlight. TILs less than 20%, interaction between TILs and treatment arm, this is significant. And if we see TILs more than 20%, there is a clear-cut separation. Thus, interaction test is positive. But if we see the overall survival, interaction between TILs and treatment arm, interaction is not significant. Though we can see there is some difference in the graphs. So it is very important to understand TILs 20% cutoff has been established as one of the standard biomarker. It is a difficult pathologist dependent, observer dependent biomarker, which we are not very used to, but it is going to be adopted very soon, I think. And this will be a huge help to identify the patients where we can de-escalate the treatment. It is not only about HER2 duration, but also chemotherapy. As we discussed the Fergen trial, there was treatment de-escalation, and how to identify that, when to identify that. This adds to the armamentarium. A simple test of the TILs, which can be done at the time of biopsy, can help us understanding something. So this trial first demonstrated that TILs is an independent prognostic factors of overall survival for HER2 positive early breast cancer patients. Patients with TILs more than 20% who de-escalate chemotherapy dose and trastuzumab duration are not exposed to excess risk of distance relapse or death, and this is further supporting the inclusion of immune-related biomarkers into the prognostic tools for HER2 positive early breast cancer. I'm a fan of microbiome-based treatments and microbiome-based treatment for especially for immunotherapy, and we are doing a study in lung cancer, and another study for head and neck cancer is already planned where we are supplementing microbiome. I think there is a abstract on the same as well. So we need to identify when to escalate, when to de-escalate based on the various factors which are coming up. Thank you and for the patient listening.